This session is being presented tonight by Michelle Rice and facilitated by HFA's VP of Public Affairs, Miriam Goldstein. So thank you both for being here, and you are up.
Great. Thanks, Janet. And I'm Miriam Goldstein. I am going to take the prerogative of introducing Michelle Rice, who needs no introduction. But as a longtime friend, I'm just going to take it. So we are so happy to have Michelle with us tonight. Until quite recently, Michelle served as the Chief External Affairs Officer with NHF, and she continues to work across many areas of healthcare, including payer relations, facilitating dialogue and collaboration between and among payers, providers, and patients. So she brings that expertise and fierce advocacy to this really key question. We've heard so much about the science from the two phenomenal presentations so far, but and teed up some of the questions that patients are going to have to ask themselves about novel therapies. But there is a whole other world of questions about access, and those revolve around how are these therapies going to be paid for? Who's going to pay for a therapy where the benefits might be experienced over a period of years? The U.S. system hasn't really been set up for that in the past. And what kind of conditions are payers going to place around who gets these therapies? So I will turn it over to you, Michelle, to answer some of these questions for us.
Well, hopefully I'm not going to be the killjoy that brings the conversation down a little bit at the end. But thank you for the introduction, and Miriam and I have worked together for a long time now, and are continuing to do some work together on these very topics. So, you know, one of the things I'd like to start off with, we call these high investment medications rather than just high cost. And part of the reason we say high investments is because in some cases we're looking at things that could be these one-time heavy, our large one-time payments, where the benefits, as Miriam said, are going to be seen over the years. So it is kind of an investment in the future by the payer. But what I wanted to say is, Dr. Pipe did a great job of talking about the kind of evolution of treatment. And for some of us who've been around for a long time, I was around, my oldest son is 32, will be 33 in a couple months. And I was around when the first recombinant product came out. And, in going from plasma-derived products to recombinant products, we saw a price increase, but again, there were still just a handful of therapies at the time. And this was, not too long after the HIV crisis. Actually, I think they kind of crossed a little bit in the time periods where people were being diagnosed, and also in the Hep C period as well. And so payers didn't question a lot the cost for these drugs, because again, it was a handful of drugs. They knew that patients didn't respond exactly the same to the different therapies. And honestly, because at that point in time, hemophilia, yes, hemophilia was expensive, but we were a little bit of a blip on the radar screen because there wasn't this huge burst of specialty drugs that we have now seen over the past, 2 decades, really, but really over this past decade, and what we know is coming out in the future. So I always like to say, if it was just about hemophilia, we wouldn't be having any of these conversations. If it was just hemophilia coming out, I don't care if the cost was $3 million. We still probably would not have these conversations. So the problem is that there are many new therapies that have come out, specialty therapies. As Dr. Pipe talked about, there's some new innovative therapies coming out. You also have this gene therapies, and Tommy referenced earlier the fact that there's cellular therapies that are coming out. So again, there's all these new therapies and, kind of what is the fuss about them? They're all expensive. And in many cases, we have little long-term data on these drugs so far. So I'm just going to kind of share with you, next slide, kind of what the conversations are around payers. And also a little bit about, let's just talk first about kind of how insurance works. The money that comes in has to be more than the money going out. Otherwise, they're not in business for very long, right? We all think and we all hear about, oh, these insurance companies make a ton of money. They're paying their employees well. What we don't hear about is sometimes plans do shut down. Sometimes, maybe it's a regional plan, maybe it's a local plan, but that does impact a lot of insured individuals. So it's important to know that. And how they set their how they choose what benefits they're going to cover and what they're going to charge for them is all about risk, right? They have to look at who are the people we insure, what do we think it's going to cost to take care of these individuals, pay the claims. And of course, many of these are still for-profit entities. Some are not for profit, but many of them are for-profit entities. So they have shareholders to report to as well. So how much is it going to cost us to take care of everyone? And are we still going to make a profit? So it's really about, the risk is they're always taking a chance that more money is going to go out than what's coming in. And so I'll explain a little bit further or a little bit later in the conversation how this is applying to all these new drugs. One of the things is that all these high investment medications have kind of brought about a need for innovative health insurance benefit designs. And what I mean by that is for years, benefit designs have stayed pretty much the same, right? You've got, those services that are always covered under medical. You have some services that are always covered under pharmacy. How they decide, for example, what drugs they're going to use under, what they're going to cover under pharmacy, they may bring in front of their pharmacy and therapeutic committees to take a look at those, but they tend to apply the same type of utilization management policies, the same type of cost management policies. Once they come up with a strategy, they tend to use that over and over again, right? The problem is that as you're getting to some of these newer therapies, it's really bringing to light that a one size fits all solution doesn't really work. For example, some of the cost saving measures that they try to use with prescription drugs, like step therapy, where you have to try this product before you can try the next product. You have to try this and fail before you can do this next one. And it may take 3 or 4 steps for you to get to the therapy that your doctor and you have agreed that you believe is going to be best for you. That may work with some other conditions. Unfortunately, with some of the specialty drugs, they could actually increase their costs by doing something like that. For example, hemophilia. Question is, what do they consider failure? If they consider failure a breakthrough bleed, maybe that could be something minor. But in most cases, when we talk about breakthrough bleeds, we're talking about a joint bleed, maybe even a head bleed or something in your GI system. Those can be life-threatening. They can certainly also be life-limiting and life-changing, which means I could have 2 or 3 joint bleeds, and now I'm going to end up starting to develop some arthritis that down the road is going to cause me additional medical costs. So they're starting to realize that they can't apply those same, solutions that they've had for years to everything. So what they've done is over the last, I'd say 5 years, maybe even 6 years, there's been a lot of various think tanks or discussion groups put together where they bring in payers, they bring in, employer groups, they bring in Medicaid programs and government officials and patient advocacy groups, to sit around a table and say, okay, what can we do differently? Miriam mentioned that, in some other countries, the ability to pay over time and actually economies of scale can help bring costs down for medications because there's one payer. Now, there's lots of questions that we could ask about, do we think a one payer system is good or bad? And that could take us down a whole other rabbit hole. But just understanding that, one of the things about our bifurcated system, which, just means we have so many different types of payers and ways in which they pay, in the US, reimbursement actually is pretty good for many medications. So it helps us spur innovation, right? It helps to get manufacturers willing to, look at new therapies. So there's a plus and a minus. But what these groups are doing is coming together and saying, how can we find a middle place, right? How can we find a way to bring costs down in a way that it doesn't limit innovation? Because of course, we'd love to see everybody cured of everything, right? How can we do that? Bring it down so it doesn't, stall innovation, but so that it's affordable and sustainable for us to keep paying for these new therapies as they come out. So what I listed here was a few different of those think tanks that have been going on for a while. And I know that HFA has probably participated in some of these, as well as NHF. Representatives from both groups have participated there. And I have participated originally while I was at NHF with AMCP, which is the Academy of Managed Care Pharmacy, and their partnership forums. And I'm still doing that now in my new role. Next slide. But there is an impact of risk on access. And again, remember what I said is risk means how much the insurance company has to pay out for claims, or how well they estimate what those costs are. And so again, I just want to remind everybody that the cost concerns aren't limited to one particular disease and or therapy. It's not just about gene therapy. I'm sure many of you have already seen more questions as more and more factor products have come out, where, we've seen insurers start to say, okay, no, we're going to have to put some guidelines around, which product you're going to choose. We've seen where they list some as preferred, some as non-preferred. We've even seen where a few are listed as non-formulary, which technically means not covered. So again, we need to remember that there's a lot of new therapies under development. So payers have to think about that when they're kind of trying to evaluate their risk. And then they also have to say, well, how many patients will be eligible to use these new therapies? And of those eligible, how many will choose to use those therapies? So there's a lot of questions for them. And what they say is it's so hard to make these decisions without data, which is where I get to the comment I made earlier about we have a lack of long-term data.
Yeah, so if I can interrupt, so the risk for the payer is also with a novel therapy that doesn't have a long track record. Is it going to keep working? Is it going to work at a level that they want, or what's the level of breakthrough bleeds or return to factor or something like that? And then is it going to keep working? Is that part of the risk calculation for them?
That is the other thing that is interesting is sometimes they do look at studies. Obviously, they always look at the studies. They look at the studies, but then the question is that how it's playing out in real life? And so I think what we've seen is, just as an example, we've seen some of the, I know Dr. Pipe had mentioned Hemophilia or emicizumab. And, I know that, when you look at some of these things that for inhibitor patients, absolutely took away, a lot of the cost, took away a lot of the burden to the patients. But then, they also look at the patients who had hemophilia and they say, is this more cost effective? Are they not having the same level of bleeding? And in some instances, what we hear is the types of questions will be asked as they're trying to think about their risk is, okay, well, we're looking at this number of patients, and in this number of patients, we're seeing a regular usage of both this new innovative therapy and traditional clotting factor. Why is that happening? And obviously, there's always exceptions to rules, which again is why I say one size doesn't fit all. But these are the kinds of questions they come back and ask us as advocacy organizations or in focus groups that we may be holding, and trying to understand that. That's one of the things that they look at with some of these other new innovative therapies coming out, such as Dr. Pipe was just explaining, is there's like, this sounds great if they change this kind of thrombin component here, will that really prevent them from needing to use clotting factor? And how much of clotting factor use in those situations is more just patient comfort level, right? Trying to adjust to a change. So, there is some recognition by payers that sometimes you may see some carryover in a switch because this is a lifestyle change. No lifestyle change happens overnight. So anyway, so hopefully I answered that question, Miriam. Next slide. So what I'm going to say here is, remember, it's all in the math, right? Health insurance companies get their revenue through monthly premiums, consumers paying deductibles and copays. Not that your deductible and copay goes to the payer, but what it does is it pays a portion of the cost. So in effect, it is more money for them because you are paying that portion, not them. And then that money that they receive is spent on healthcare provided to their members. Now, you may remember that the ACA put limits on small group plans, marketplace plans, ACA compliant, even large group plans, on how much they can spend in administration dollars in compared to spending it on actual medical expenses. And there's a requirement that if they go over that percentage, they have to return that overage, those overage payments to, unfortunately, usually to the employer, whoever is actually the one paying for the premium. But I just wanted to give you an example. And this is just taking one state's Medicaid program into consideration. Okay, I have a state where right now they have 400 patients with bleeding disorders on their Medicaid program. Right in 2022, a gene therapy came out for beta thalassemia. And let's say that there's 20 patients that are eligible for that, and it's $2.5 million. Well, let's say that the state's Medicaid budget is $1 billion. So for those 20 patients to get that, it's going to cost $50 million. Yes, that's a lot of money. But is it so much that it's going to put them over their cost? I have yes in here that it's okay, that they'll be able to pay it, but I'm going to change that to a maybe. Because if you look above, they have 1,872,810 members. Now, of course, not everybody on there is using medical services, and they're also not using them to that high of a limit in a year. But again, remember, this 50 million is for 20 patients out of that whole amount. So I'm trying to give you just a level set on what payers are looking at when they're thinking about, can we cover these drugs or not? So now looks like there may be an additional 2 therapies, at least 2 or 3, that are going to come out in 2023, gene therapies. And this is just in the area of bleeding disorders. It's in sickle cell, hemophilia, and as I said, this beta thalassemia. Well, now let's say we're going to add 100 patients that are eligible, that choose to do it. All of a sudden, it's 250 million out of $1 billion. Are they going to be able to do that? Chances are the answer is no. If they have over 1 million members, think about it. They are going to spend 25% of their budget on just 100 of those members. So these are the kinds of risk questions they have to ask themselves. And one thing about Medicaid that I will make a point of saying is Medicaid, unlike the federal government, state budgets have to be, they have to reconcile their budgets every year. They cannot run a deficit budget. So again, they have to be within that rate. They have a certain amount they can spend in a year, and they have to plan for that. So this is why it's very difficult, especially for the Medicaid population, to be looking at this kind of cost. Let me also say, if you were a employer group, and some of you may be aware of the fact that employer plans are either fully insured or self-insured. Self-insured means the employer is the one writing the check. They look at what they think their costs are going to be for the year. They set that money aside. They typically hire an insurance company to act as what they call a third-party administrator. That person will actually allow, or that company, they will use that insurance company's provider network. A lot of times they will handle all of the administrative work for them, doing the billing, receiving the bills, all that. But at the end of the day, it's the employer who writes the check. Let's imagine you are in a company that has 100 employees and you have 5 employees who need a gene therapy. We're talking about we're talking about $12.5 million for 5 people for a firm that only has 100 people. This could really impact, when you think about what that company's overall budget is. $12.5 million could be enough to put that company out of business. Again, this is the kind of conversation that payers are having. And when I say payers, I mean Medicaid, Medicare, the marketplace, commercial health plans, if you're going through the marketplace. So just so you know, there's this is a lot that someone has to plan for. I break out in hives thinking about how they do this. I have a hard enough time doing my own budget, my own household budget. So next slide, please. So you can see why access may become more difficult, right? And we've already started to see some of this leading up to, some of these new medications coming out. What we've seen over the last, it started in 2016. end of 2016, beginning of 2017, we've seen accumulator adjusters come out, which for those of you who may not know, an accumulator adjuster is where if you are using a manufacturer's copay card, which many of us in this community have done for many years, because our out-of-pocket costs we hit every year. It used to be that using that manufacturer copay card counted towards your deductible and your out-of-pocket. Accumulator adjusters made it so that that is not the case anymore. They will still let you use them, but once you use up that card, then you have to go back and pay your full deductible and your copay before you get your medication. We then saw maybe a year and a half later, 2 years, a pickup in a program called Accumulator Maximizers. Very similar in some regards, but it actually requires you to use the manufacturer's copay card. But what it does is it spreads that money out over 12 months. But the idea being that, oh, you won't ever get hit with a large amount at one time. They haven't really met us yet because that does happen. We're also seeing to see stricter utilization management policies, especially as you're looking to change to a new drug. You know, now it becomes, well, explain to us why you need to change. Why is this not working? We don't see that you're bleeding that much. How is this not working? Prove to us that it's medically necessary for you to move to this. There's also more steps to plan for your medication, you know, or plan to approve your medication. You know, it used to be that once a year, your doctor could send in something at the beginning of the year that says this person has hemophilia A or hemophilia B. Here is the prescription therapy that we've decided to use for this patient. And you could get your factor every month after that. And then at the beginning of the next year, you would have to get another approval. What we started to see was that as insurers started to understand a little bit more about hemophilia, they said, well, you know what? We're going to make it so you have to do that every 6 months. And then all of a sudden it became every quarter. And then there was even a few insurers who said you had to do it every month. Why is that a problem? I have 2 boys with severe hemophilia. I have mild hemophilia. And I don't care how well I planned. Sometimes life gets in the way. It gets to be a Friday and you're like, uh-oh, I don't have any factor for the weekend. And I assure you that you call on a Friday morning to get that prior authorization, you are not receiving factor until the next week. So again, these were steps that they put in place to try to be able to better track how factor is being utilized, to make sure that there was no auto shipping, lots of different reasons. But really what it amounts to is delays for us. Then we've had a new one that has come up in the last 2 years, which at NHF, we started calling these alternative funding schemes. I wrote in here mechanisms because I was trying to be nice. But these are programs that are being sold specifically to self-insured employers that leads them to exclude coverage for specialty medications. And unfortunately, we are seeing this in the hemophilia community, and it has gotten worse in the last year. And basically, what this program does is they tell the employer, we can help you get this product cheaper. In a lot of cases, we can get it for you free. And the way they explain it is that they're going to work with international pharmacies, they're going to work with charitable programs, and they're going to work with manufacturers' patient assistance programs, which basically what they do is they falsely, in our minds, falsely say that these drugs are not covered, and so that they can go out and sign you up for a manufacturer's copay program, or I mean, patient assistance program. The problem is that not everyone is going to qualify. And what they've told employers is, well, if the person doesn't qualify for one of these programs, you can always make a medical exception and pay for it under your medical policy. The key word there is can. And quite honestly, when a payer is able to offset and push out somebody that was costing them $300,000 or $400,000 a year, the likelihood of them saying, oh, okay, well, we'll go ahead and add it back. They are hurting some from COVID as well. They're looking at all of these new drugs coming out and they're like, hey, if we can get them free, we'll take them for free. So just so you know, there are several different things that are happening. Again, in our community, in the bleeding disorder community, we're very lucky. NHF is working on these things. HFA is working on these things. They are very aware. They are very involved. This is something that in all of my work with payers, I talk to them about the unintended consequences of implementing these programs. So they are hearing from a lot of us. We've been able to make some changes in some health plans. But thinking about what I told you earlier about the numbers and how much it costs, you can see how some of these things might be of interest to these groups and might be very tempting for them to utilize. So what is the answer, right? We've talked about all the problems. What is the answer? One of the first things that a payer would say to you, if you said, what is the answer? How do we fix this? They would say, you make pharma lower their prices. Well, look, there's a lot of people who have their fingers in the pie and whose actions impact healthcare costs. So the answer is it legislation, regulation, value-based agreements, which is one of the new, payment models, or annuities, which is a payment model? The answer is probably a little bit of all of those things, but also consumers have a responsibility too, right? To be adherent to their therapies, to not allow a specialty pharmacy or a pharmacy provider to auto ship them drugs that they don't need. Everybody has a piece of the pie when it comes to finding a solution for these healthcare costs. And it's going to be difficult for many of us in the US because, quite honestly, we have been very lucky. And as I believe Miriam mentioned, other countries, honestly, one of the reasons that they are able to get their drugs and their care for less money is because the US pays so much for those things. So again, there's a lot to do, but the most important thing is, to me, the first answer is to have a seat at the table and participate in the conversation, and to try to take ownership of what we can fix and encourage others to do the same. So
that's a really rousing note to finish on. I know we're a little over time. There was a question in the Q&A about your example earlier on with talking about the stresses on the system if there are multiple gene therapies, and pointing out that Tommy had said there aren't any yet. I answered, I hope correctly, that you were kind of speaking hypothetically and looking ahead, because there are other therapies in the pipeline, including for sickle cell and beta thalassemia. But that did tee up one question, if we've got time for that, which is, are payers going to look differently at Hemophilia, where we do have a range of products available that do not work perfectly for all. I think Dr. Pipe's presentation really showed where some of the gaps are, but we do have products, as opposed to a beta thalassemia or a sickle cell, where maybe there isn't anything that the new therapy would be competing with or adding to.
I do think there are going to be concerns like that. I mean, I've been in meetings already where the question has come up, how do we make a decision about a therapy when, some of these are life-saving, some are life-altering. And I can tell you it gets brought up a lot in payer conversations around gene therapy, where they say, you all have a lot of therapies that are working fairly well for community members. I think that in some cases will allow some payers to feel like, all right, for those gene therapies that come out, if it's life-saving and there's no other treatment, we should make those a priority. They have expressed concerns, at least in the meetings that I've been in, and I recently hosted one that Miriam, you attended as well. They're concerned about all of the gene therapies and their costs, because I want to be able to approve them for everyone. And I think that they're also very concerned, not just about the cost, they're concerned about the long-term effects. Are we going to see problems down the road that we haven't seen yet? There's not a lot of data on really any of these therapies. And so, but I think that concern gets a little less important in those scenarios where there's no other treatment and they know those children will die. That is one of those cases where they've, I've heard a lot of them say, well, we're going to make it work. Somehow we're going to make it work. But I do think, and it will all depend. It will depend. I did say that I know that there are 3 gene therapies up for review right now, or actually 3, maybe 4, that are bleeding disorder related. A couple in hemophilia, a couple in sickle cell. And so that was where I was kind of giving the reference to 2023. But I also know that there's gene therapies that are looking towards, are moving at some point that are in other disease states as well. So, you have some, Duchenne's has some gene therapies potentially coming out, and that is where there will be thousands of people eligible. So again, the problem is that, if history shows us anything, if something gets approved for a certain dollar amount, then all the other things like it are going to ask for the same amount of money. So all of a sudden you may have 250 gene therapies that are all asking for $2.5 million in costs. And the meeting that we attended, there was a lot of conversation around, there are some real risks to employer-sponsored insurance right now. Many employers are saying, we are not going to cover any gene therapies until we have more data. So again, they may be saying that now. We'll see what they actually do in 2023. But that is what we were hearing, was that I think the number we had heard was probably 50-60% were already starting to say we're not going to cover gene therapies until we have more long-term data.
And that highlights just another area of patient responsibility that you talked about, and patient engagement, which is we as national organizations have called on the drug sponsors to conduct follow-up studies. We know that long-term data is needed, but that means patients are going to have to participate. They're going to have to sign up for the registries. They're going to have to keep going to their doctors, no matter if they feel like bleeds are in their rear view mirror. So another way to claim that seat at the table.
Absolutely. Thank you for pointing that out, because it's hard when you've been going all those times to the center to all of a sudden go, you get that one-time shot and you think, okay, now I don't have to do it anymore, but you still do need to. For the follow-up.
Well, thank you so much, Michelle. I think we could talk all night, but that might try the patience of our audience. So,
Yeah.
Janet, I will turn it back over to you.